Oh yeah. I'm going back through Sketchy again.
Is it
Oh,
C.
C. diff. That's right.
Yeah.
Oh, that makes sense. Ew.
Okay. All right, I'll go ahead and start if everyone's good. And hit the last 4 lectures and then we'll be done. Okay, so antiretrovirals. I had somebody message me this morning and said that they're having trouble keeping the class and mechanism of action of the viral drug straight. And this was like the best thing I could come up with. Um, so this is off. I don't even remember. It's not Dirty Medicine. It's something I haven't watched before. But okay, so this was this guy's idea. So for your fusion inhibitors, you have this guy standing between a rock and a tide, and he's supposed to do the fusion inhibitor. So Maraviroc and Infuvertide. And then your protease inhibitors, just trying to save you watching the video. Protease inhibitors, Naver or Never Tza Pro, Integrase. She said in the lecture, I mean, normally people say like to remember like the suffix like Gravier, but if you notice in the middle here, it has TEGR, which doesn't mean anything, but it might help you remember that it's integrase inhibitor. And then in RTIs, the N, there's an N in the middle, so Veer is also in the middle. And then NRTIs is everything that's left over. So I don't know, it might help you a little bit, keep them sorted out. Otherwise, other than just like relying on the suffixes or, the little, what do they call them, infixes that are in the middle of the drug names, I really don't have any good way to remember these. Either that or just like brute force. Okay, so start with the entry inhibitors. So your fusion inhibitor is an Infuvertide, and not in red. I think if you just remember it's a fusion inhibitor, it's good enough. But more specifically, it's going to bind GP41 and prevent the conformation change required for fusion of viral and cellular membranes. And then adverse effects. In 98% of patients, they will have a site reaction, which can consist of erythema, nodules, and cysts. So for that reason, not really a favorite drug choice for a lot of people. And then your binding inhibitor is Maraviroc, and this one is going to bind a host cell CCR5 receptors to block binding of viral GP120. And the big thing to know here is that tropism testing needs to be performed to ensure the virus actually uses the CCR5 receptors. So I feel like that makes sense because you're not going to give a drug that targets this receptor if that virus strain does not use it. All right, NRTIs. The one that she asked about last year, and with Dr. Weaver, anytime she circles something a lot of times or puts stars by it, it almost is always on the exam. So I would definitely know about zidovudine, especially the fact that you're going to give it IV during labor and delivery to prevent transmission to the fetus, and then you're going to give it orally for 6 weeks to the newborn once it's delivered. Then specific to zidovudine, you can see insulin resistance and dyslipidemia. And then applying to all of these, you'll see mitochondrial toxicity and lactic acidosis. And then also she mentioned when you're choosing drugs, you don't want to pick two analogs at the same base. So you don't want to pick, for example, two thymidine analogs like zidovudine and tenofovir. You would not want to combine those. Okay. And in RTIs are efavirenz and dalvirudine. So remember the vir in the middle and the n in the middle, or n for not at the end. Your suffix is not at the end. These are all substrates for CYP3A4, and the one that she made a pretty big deal about is the fact that efavirenz is teratogenic. So, of course, this means that you're not going to want to give this drug to a pregnant female. For integrase strand inhibitors, the one to know is raltegravir. And I'm assuming since I didn't put it in red, she didn't have anything else in red in this slide, so I would just focus on the mechanism of action here. I mean, as you know, you can trust her red text, I feel like. Okay, our navirs, so never-tizapro, the protease inhibitors, they're going to prevent metamorphosis of HIV into the mature form by preventing proteolytic cleavage of protease inhibitors. And I think, as far as the exam goes, and as far as like the mechanism of action on the exam, if you know what's at the top here, like if you know that it's an NRTI or that it's an integrase strand inhibitor, that should be enough to get you the question correct. Like as far as like how she goes into more specifics with the mechanism of action, I don't really remember that being necessary to answer the question, so hopefully that helps. So she spent a lot of time down here. So make sure you know that ritonavir is used as an enhancer. So this means that if you give someone a protease inhibitor, you can also give a booster like ritonavir. And ritonavir is going to help the drug stick around longer because it's a CYP3A4 inhibitor. So a lot of these drugs are CYP3A4 substrates. So if you inhibit CYP3A4 and you prevent the metabolism of these drugs, then the drug is going to stick around longer. And then also she mentioned this drug called cobicistat. It's also a CYP3A4 inhibitor used to boost the levels of other drugs. And two important adverse effects are hyperglycemia and lipodystrophy. So, and she, spent a lot of time on this. So I kind of think that, you could see a question from in here. But she said, if a patient's body is using a viral aspartic protease, and then you give them a protease inhibitor, you're going to see hyperglycemia because the patient cannot cleave proinsulin to insulin and C-peptide. All right, so a patient who's prescribed enfuvirtide as part of her ART medication regimen, what is the mechanism of action of this drug? Right, so enfuvirtide is a fusion inhibitor. So if I were to guess, that's fine. If I were to guess, I would expect like maybe one mechanism of action related question, something about, adverse effects, and then something about like when not to use a drug. Okay, so a 45-year-old HIV positive male is on ART therapy, presents to the clinic with a blood glucose of 250 and an accumulation of fat on the back of his neck. Which drug likely caused his presentation? Right, good. Ritonavir. So hyperglycemia and the lipodystrophy. A 30-year-old HIV positive pregnant female is in labor. What is the next best step to prevent transmission of HIV to the fetus? Right, so the correct answer here is D. You want to give the patient in labor IV zidovudine and then give the infant oral zidovudine for 6 weeks following delivery. And I definitely remember this one being on the exam last year. So hopefully that's a 1 of 3. Why would you not give a pregnant female efavirenz? Right, it's teratogenic. Okay, moving on to ocular pharmacology. And we didn't have this lecture last year, so I mean, I can only guess like what he might ask. All right, so just kind of an overhead, don't forget that your sympathomimetic drugs cause dilation or mydriasis, and then your parasympathetic or parasympathomimetic drugs are causing constriction. And then in opioid overdose, you're going to see pinpoint pupils. Okay, with alpha 1 activation, you're going to see mydriasis, and then with M3 activation, you see meiosis. So just remember sympathetic versus parasympathetic. And then your beta 2 is responsible for aqueous production as well as relaxation of the ciliary muscle, and then M3 accommodation. So M3 meiosis and accommodation. Okay. I think you guys are probably good with this because I believe the last neuro lectures with scoring is a lot of glaucoma. So glaucoma, you have a blocked drainage system, which leads to an increase in intraocular pressure, which can cause optic nerve damage and vision loss. I threw this in here from first aid just because it gives you where the drugs that he talked about are acting. So just another way to look at it, if that is helpful. All right, so what I did here is he had the charts at the end, but then of course, he had all the info in the slides. So I tried to compare the charts to the slides and, mesh together the best of both, like what seemed, what he had in red and what seemed important. So hopefully this will narrow it down. But he talked about 2 classes of drugs that are going to decrease aqueous humor formation. So first are your beta blockers, and so beta blocker blockade is going to prevent catecholamine stimulation in this pathway, and you're going to see a decrease in intracellular CAMP and a decrease in aqueous humor production. So that's mediated by this cyclic AMP PK pathway. And then your adverse effects, bradycardia, heart failure, and depression. Your carbonic anhydrase inhibitors to know are dazolamide and brinzolamide. And these, of course, inhibit carbonic anhydrase in the ciliary epithelium, and they're going to decrease the formation of bicarbonate ions because you're inhibiting carbonic anhydrase, and decrease fluid transport and aqueous humor production. So kind of unique here is an allergic reaction, which is sulfonamide related. So if a patient is allergic to sulfonamide drugs, you're not going to want to give them one of these carbonic anhydrase inhibitors. All right, so our drugs that increase outflow, the first one is pilocarpine, and it causes muscarinic-induced contraction. So I think, Dr. Babos spent a lot of time on pilocarpine. Dipivefrin is your mixed alpha and beta agonist. And this one, along with the prostaglandin analogs, are both going to decrease intraocular pressure by facilitating aqueous outflow through the uveoscleral route. And then if I were to guess, it wouldn't surprise me if he didn't ask about latanoprost, because he mentioned that this was first line therapy. So typically anytime, something is first line, I would definitely know it. And also it has these really unique adverse effects, which include pigmentation of the iris and increased thickness of the eyelashes. So I would watch out for that in question stems. All right, and then finally, the one that is decreasing aqueous humor production and increasing outflow. This is brimodidine. And it can do two things. So either pre or postsynaptic alpha-2 activation, decreasing the intraocular pressure or decreasing aqueous humor production. So I would focus on a mechanism of action, and then maybe these two with, unique adverse effects, allergic reaction, and then the eyelash, increased thickness of the eyelashes. Okay, this is an important one. So cycloplegia and mydriasis, the muscarinic antagonist is cyclopentolate, and it's going to cause dilation of the pupil and as well as paralysis of accommodation. So this can be used to visualize internal structures of the eye. The next one is your ophthalmic NSAIDs, diclofenac sodium. Sorry about that. Diclofenac sodium ophthalmic. So this is used in post-operative inflammation, and it reduces pain after corneal refractive surgery. And he made a pretty big deal about, making sure that you don't use this drug in patients with severe renal insufficiency. And here's just a reminder, so you can think about where prostaglandins are acting versus your angiotensin II, and why you don't want to give NSAIDs to a patient with renal problems. Okay, so ocular decongestants. Phenylephrine is a postsynaptic alpha-1 agonist, which vasoconstricts and causes mydriasis. Highly doubt he would ask you about this one just because it was hit so hard a couple exams ago. All right, glucocorticoids, dexamethasone and prednisolone. These are both anti-inflammatory, and they are used topically, postoperatively following corneal or intraocular surgery. And then they're used intravitreal below the Tenon's capsule in age-related macular degeneration. Do you guys know what Tenon's capsule is? No? Okay, so it's like a fascial sheath that surrounds the eyeball. So it's going to separate like the tissue of the eyeball from the periorbital fat. Does that make sense? If not, just give it a quick Google. Okay, so you have a 65-year-old female with open ankle glaucoma, prescribed a treatment regimen that included latanoprost Which of the following actions on aqueous humor most likely mediated the therapeutic effect? So I basically stole Dr. Quadri's question and I just gave you a different drug. Very good. So the correct answer is B. So I would just take this question, and he said that this would be very similar to the exam. So I'd take this question, and next to each one, I would like write out which drugs are acting by the different mechanisms listed here. Okay, so a 7-year-old male. Sorry, typo. Is on today's schedule. Oh, I just gave you the answer. Okay, so he's on today's schedule for corneal refractive surgery. His blood pressure is a little high, normal pulse, GFR is 40, so he has renal problems. So you're not going to give him what? Right, A. Diclofenac sodium ophthalmic. He mentioned that the glucocorticoids aren't necessarily a great idea in people with renal problems either, but as long as it's like short-term use, then I guess it's okay. Okay, moving along. Okay, so with this toxicology and toxidromes lecture, I just focused on the 3 things she had in red because I feel like you can definitely trust that. Oh, with the exception of this, just because sometimes I have a tendency to confuse acetaminophen versus aspirin toxicity. So just in case, with your acetaminophen toxicity, you have a chronic alcoholic, and that's going to induce CYP2E1 and increase the formation of NAPQI. This is initially inactivated by glutathione, but your reserves get depleted. Also, in patients who are malnourished, which is common in alcoholics because they're drinking all of their calories instead of eating, it's going to push the metabolism of acetaminophen towards this toxic metabolite and lead to hepatic necrosis. And your antidote for this is N-acetylcysteine. Okay, so the first thing she had in red, I definitely remember this on the exam last year too. So you need to know that with aspirin overdose, one of the cardinal signs is ringing in the ears. So big tip off if you see ringing in the ears and questions them that they're probably talking about aspirin. But I think the thing that she'll probably test you on is the fact that patients will have a respiratory alkalosis followed by a concomitant metabolic acidosis. So you have a lack of ATP being produced in the mitochondria, which leads to increased respiration because your body wants O2 to make ATP, and this leads to a respiratory alkalosis because you're blowing off all that CO2. And then also you have an inability to use oxidative phosphorylation. So you shift the anaerobic metabolism of pyruvate, and this leads to metabolic acidosis. So just remember, respiratory alkalosis and metabolic acidosis are associated with aspirin overdose. Okay. So this chart is out of her lecture, and the point here is just to make sure that you know the difference between the effects of a muscarinic agonist and the effects of an acetylcholine esterase inhibitor. So I have the important things highlighted in red, but the 3 things that'll probably tip you off that it's acetylcholine esterase inhibitor versus muscarinic agonist is hypertension, muscle fasciculations, and then hyperkalemia. So if you see those three things, especially the muscle fasciculations, you're dealing with an acetylcholine esterase inhibitor, because you're increasing, by adding an acetylcholine esterase inhibitor, you're increasing acetylcholine everywhere it is, so you're acting at that NM junction, and that is what's giving you the muscle fasciculations. Okay, so just a reminder, if you need to go back and review where acetylcholine is acting and where your muscarinic receptors are. Okay, again, so I thought this chart she added was really good. So if it's acetylcholinesterase inhibition, look for muscle fasciculations and hypertension. And then if it's a direct-acting muscarinic, you might see hypotension or normal blood pressure. And then you won't see any skeletal muscle involvement, because you're just affecting the muscarinic receptors rather than increasing acetylcholine acting on the NM receptor. Okay. As long as you remember your anti-muscarinic toxidrome, like you should be able to recognize that it's anti-muscarinic as a stem. So just remember, hot as a hare, red as a beet, dry as a bone, mad as a hatter, blind as a bat, full as a flask. And, think back to your anti-muscarinic side effects. So no sweating, peripheral vasodilation, so the person's going to be flushed, confused, and mydriasis, encycloplegia, because of the anti-muscarinic, and then also urinary retention. All right. So 50-year-old female exposed to unknown toxin, is confused. See muscle fasciculations. Pupils are equal round, pinpoint, not reactive to light in combination. She has watery eyes, salariae, fecal and urinary incontinence, and she's diaphoretic with cool and pale skin. What is the mechanism of action of the toxin she was likely exposed to? Also, the hypertension. Right. So acetylcholine esterase inhibitor. Yeah, so just look with these, toxic overdose related questions, just look for your hints. So in this one, hypertension and muscle fasciculations. Okay, 18-year-old male with an intentional overdose of aspirin reports nausea, vomiting, and ringing in the ears. You predict his ABG results will show which of the following? Yeah, so correct answer is A, respiratory alkalosis, because you're blowing off the CO2, and then metabolic acidosis. Okay, one more. 11-year-old boy brought to the ER by some of his friends because he started going crazy, eating seeds from a plant while trying to get high. Boy was incoherent, his skin was hot and dry, pupillars were dilated, so mydriasis, and unresponsive to light, high blood pressure, pulse, rectal temp. Yeah, you guys got it. Yeah. So muscarinic antagonist. Okay, one more. Environmental toxins. So snippet from first aid, just for some extra reading to help clarify, but cyanide poisoning can occur from things like fires, so burning carpets and textiles, or the one she had in her slides was specifically a wool fire. Occupational, so someone working in the plastic or rubber industry, like the plant catches on fire. Also, sodium nitroprusside, which I don't think she'll touch that because that gets covered in cardio next year. And then stone fruits. She had apricots in red. So I guess that's a possibility. With cyanide poisoning, cyanide is going to bind to the ferric iron in the mitochondrial cytochrome complex 4, and that's going to inhibit oxidase phosphorylation. And then your cell is going to jump to anaerobic metabolism, and you'll see an accumulation of lactic acid and a metabolic acidosis and a functional hypoxia. So the cells cannot use oxygen because cyanide is bound to complex 4. And then, I don't know, this is sort of embarrassing to admit, but hopefully I'm not the only one. For the longest time, I had the trouble remembering the difference between ferric and ferrous iron. So to help you out, ferrous, in case I'm not the only one, ferrous iron, if you remember just the two of us, so the two and the us, hopefully, you'll never forget the difference. Yeah, you'll never forget the difference again. Yeah, you're welcome. Yeah, because sometimes they'll put in questions, they'll just say ferric or ferrous, and they won't actually write it out. So hopefully that helped me a lot the first time I saw that. Okay, so anyways, your symptoms. So they're going to give the patient O2 and they're not going to respond to the supplemental O2. So that's kind of a big hint. And again, that's because your cyanide is bound to complex 4. And then also CNS effects like headaches, confusion, and vertigo. And then your antidote here is sodium nitrite. So cyanide has a higher affinity for ferric iron than ferrous iron. So you're going to induce methemoglobinemia that has that ferric iron by giving nitrates. And that's to get the cyanide to bind and to trap it. All right. She might use that. Oh, yeah, that's a good point. With iron toxicity, so your acute effects of iron toxicity are a necrotizing gastroenteritis, so nausea, vomiting, pain, bloody diarrhea, shock, metabolic acidosis, hepatotoxicity, just a lot of bad GI effects. And then also iron is a radio opaque on x-ray. So if she gives you a picture or an x-ray, you might see a lot of radio opaque spots. And then your antidote for this is deferoxamine, which binds the ferric iron. And also, I believe she had in red the fact that some patients will see symptoms from an immune response, so histamine release and vasodilation. Yeah, and then you can see in first aid they mentioned the deferoxamine. Okay. Oh, and I did a little bit of reading, and I guess a common presentation of this, like in the ER, is like young kids who get in, a pill bottle with iron pills, and then you see like the radio opaque iron tablets on X-ray. Like there was a lot of like pediatric journal articles related to that. Okay, so the last one here, lead poisoning. So lead is going to inhibit these two enzymes here, so ferrochelatase and ALA dehydratase. And in the urine, in blood and urine, you're going to see an elevation in delta ALA. And then the marker in the red blood cells is protoporphyrin 9. And I'm pretty sure that question will probably be something related to the fact that you're going to see increased urinary excretion of delta ALA. And then lead poisoning, I mean, I think most people are familiar with that, like, paint from old houses, plumbing, apparently imported food packaging, and then moonshine. So her mnemonic was lead. So you see the metaphyseal bands, encephalopathy, anemia, which is a microcytic hypochromic anemia. So I included a histo slide for you in case that shows up. So you'll see basophilic stippling, and then the ring sideroblasts, and then also both wrist and ankle drop. And your antidote here was calcium disodium EDTA. But she definitely, I mean, in my opinion, she made it sound like she was going to ask you something about the pathway over here. So I would just make sure you know the red blood cell marker, and then the marker in the blood and urine, especially the delta ALA. Okay, yep, and I just included this too. Okay, so a 45-year-old female presents to the ED after a fire at the Red Factory. She's confused and reports having a headache, nausea, and vomiting. Physical exam, she's hypoxic and tachycardic. She has an almond odor and her cheeks are flush. Doesn't improve with supplemental O2. What are you going to treat her with? Right, so sodium nitrite. And then, so here we go. A 4-year-old female presents to the ED after ingestion of a bottle of pills without a label. Abdominal x-ray reveals many radiopaque areas. Which of the following can you use to treat this patient? Right, so deferoxamine. Okay. And then one more. 2-year-old female, teething and chewing on objects found in the home. She's been fussy and lethargic and pale. She's been clutching her abdomen in pain and refusing to eat. Laboratory testing reveals elevated free erythrocyte protoporphyrin, along with this finding on the blood smear. Which of the following do you expect to be elevated on a urine screen? Those were probably Flintstone findings. I don't know. I feel like I should have been in the ER with I ate those things like candy when I was a kid. Like a whole bottle, yeah. All right. Any questions? I'm sure you guys are so excited to be almost done. Yeah, you're very welcome. Yeah, it was really fun getting to know you guys. I'm gonna miss you guys too. Thank you. Yeah, just feel free if you ever need anything, even, second year, just, shoot me a message anytime or anytime this summer. And good luck this Friday.